Okay, let's move on and talk about pacemakers next. Y'all, we know this, that the heart has a natural pacemaker called the sinus node or SA node. The sinus node, it sends out an impulse that makes the heart contract. So what happens to your cardiac output if the natural electrical system malfunctions and the heart rate drops to 60 or below? Well, the cardiac output's going to go down, decrease. And when your cardiac output decreases, are you perfusing your body properly? No. Okay, so pacemakers are used to increase the heart rate with symptomatic bradycardia. Pacemakers depolarize the heart muscle and a resultant contraction will occur. You know, when I say depolarize, I'm talking about the electricity going through heart muscle. Repolarization, this is when the ventricles are resting and filling up with blood. An easy way to remember this, circle RE in repolarization. So you remember, RE equals rest. The heart is resting and filling up with blood during repolarization. Now, pacemakers may be temporary, permanent. Let's talk about temporary first. They are usually used in an emergency situation. Maybe after heart surgery, or if somebody's having an acute MI, a heart attack, or until the client is stable enough for permanent pacemaker to be inserted. Okay, now the pacemakers, they're classified as invasive or non-invasive pacemakers. Let's start with non-invasive temporary pacing. It's also called transcutaneous pacing. This is the one you probably will see in the emergency department. They apply 2 large electrode pads to the client and turn the defibrillator to pacing mode. They've got to turn it to the pacing mode. Okay, this isn't just any defibrillator. They've got to turn it to pacemaker mode. This is strictly an emergency procedure that's used until another measure can be done. Now, since these pads are on the skin, the impulse must go through the skin, chest wall, and chest muscles. Hey, is this going to hurt? Yes. So the client will need analgesics. So be sure and think about that as a nurse. An invasive temporary pacemaker has pacing wires that have actually been placed into the heart chamber. Okay? The MD inserts the pacemaker wires through a large vein and into heart chamber. Okay? It's called transvenous pacing. These wires are connected to a power source that's outside the body. This power source is called a pulse generator, and it looks like a small box with dials on it or some buttons that you can push. Okay? The power source is a household battery. So the nursey thing is, don't forget, check the battery. Okay? You've got to check the battery. Now there's this other thing. They might do temporary pacing. They might do epicardial pacing. This is when the wires are attached to the epicardium during heart surgery. These wires are connected to the same power source, and the same power source then paces the patient. Okay? It's the same as a transvenous power source. Now, transcutaneous, transvenous, or epicardial, those are all temporary types of pacing. Now, permanent pacemakers. The permanent pacemaker is used when the patient has a chronic heart condition, okay? When their heart condition is chronic, okay? These wires are now anchored to the endocardium, okay? And that's attached to the battery source. It's implanted in the subcutaneous pocket. The pocket is usually, you've seen them, under the clavicle, sometimes the abdomen. You just need a little fatty area that will support the battery. Any pacemaker will maintain a certain minimum heart rate, just depending on the settings. Okay, a demand pacemaker is going to kick in when the client needs it to, when it's demanded to turn on. Okay, so let's pretend I have a demand pacemaker and the low rate is set at 70 for my pacemaker. As long as my own pulse is above 70 or above, what's my pacemaker going to do? Nothing. It's turned off. Okay, but if for some reason my heart rate drops to 50, now what's my pacemaker going to do? Kick in, turn back on. Okay, it's demanded to kick in. A fixed rate pacemaker fires at a fixed rate constantly. It's okay for the rate to increase, but never ever decrease. Never decrease. Always worry if the rate drops. Always worry if the rate drops below the set rate. Okay, post-procedure. When we're talking about, right now, we're talking about permanent pacemakers. Post-procedure, monitor the incision. Sometimes pacemakers are here or here, just depends on the patient. So we're monitoring the incision. Now the most common complication in the early hours is electrode displacement. Electrode displacement. In other words, the wires, they pull out. Depending on the type of pacemaker somebody has, there's wires going into different chambers. Well, those wires, it takes a while for them to get embedded in the heart muscle. Okay, that's why it says on your handout to immobilize the arm. Immobilize the arm, okay? Well, if somebody's arm is immobilized, we better be doing passive range of motion. So the client does not get a frozen shoulder. So they don't get the frozen shoulder. Also this, do not allow this client to raise their arm above shoulder level. Okay, because I'm worried of electrode displacement. Now, signs and symptoms of malfunction. You know, remember earlier I said pacemakers depolarize the heart muscle and a resulting contraction will occur. Well, that's what we hope for. Hopefully that will occur. I'm saying hopefully here because is it possible for a pacemaker to fire, send out the stimuli, and nothing happens? Yes. Is it possible no mechanical event or contraction follows the stimuli? And what is this called? Loss of capture. Loss of capture. It's a pacemaker malfunction. And that scares me because if it happens a lot, it could affect my cardiac output. Okay, now what can cause loss of capture or malfunction? Well, on the handout, you have some things listed for you. The pacemaker may not be programmed correctly. That can happen. Or the electrode can dislodge. Dislodgement of the electrode. Or, we've already said, the battery can be depleted. Any one of those things. So what am I watching for? Any sign of a decreased cardiac output or decreased rate? I love both of those answers, but my favorite answer, if I had to pick between the two, would be decreased rate. Decreased rate. Because that's more concrete. That's more concrete to assess their rate. So we check the client's pulse. So client education is next. They need to learn to check what every single day? Their pulse, yes, to make sure the pacemaker is still working. They need to carry a little ID card that they can carry with them all the time that tells people about their pacemaker, okay? They need to avoid electromagnetic fields. They've got to avoid electromagnetic fields because the electromagnetism can interfere with the pacemaker. Things like cell phones, they should be used on the opposite ear. Yes, large motors. Okay, so don't let Granny weed whack with the gas-powered mower. That's not a good thing. Okay, so large motors, arc welding, electric substations. The next thing it says, stay away from MRIs. Now let's figure out this MRI thing, okay? The pacemaker. What's it made of? Metal. Yes, and the MRI, what is it? Well, it's a magnet. So when you put the patient in the MRI, their pacemaker can pop out, and there they are, holding it in their hand, wondering what to do with it. Okay, I'm just kidding. See, magnets can change the programming on a pacemaker. Change the programming. They can also turn off my pacemaker. So let's stay away from MRI machine. Hey, are they going to set off the alarms at the airport? You know what? They should not be going through the normal line at the airport. They have to go through that little special door. Okay? They should not go through the security machine, because you know that security machine, that's a magnet. And we're staying away from the magnets. So they go through that special door. And they're going to be patted down. And those ladies, they're going to use the wand on the patient. They're going to use a wand, but they should not go above the level of the umbilicus. They got to stay below the umbilicus. And the last thing it says on your handout is this, that the patient should avoid contact sports. They should avoid the contact sports. And you're thinking to yourself, Granny, with the pacemaker? Why would she be playing contact sports? Hey, are there young people that get pacemakers? Yes, young people get pacemakers too. We just do not want any trauma to the site. No trauma to the site. Okay, now I'm going to talk about a couple of things real quick. You've probably heard people have these things called implantable cardiac devices. Some books call it implantable cardiac defibrillator. Well, here's the deal. This device that the patient has, the ICD device, they're so fancy. They can defibrillate the heart. They can speed up a slow rhythm or slow down a fast rhythm. There's lots of fancy devices out there. If you understood everything I just said on these pages, you're fine. You'll be good for the test. Okay? Let's move on and talk about heart failure. Let's look at causes first. Okay, heart failure is a complication that can result from problems such as cardiomyopathy, valvular heart disease, endocarditis, or acute MI, and hypertension. Hypertension is the leading cause of heart failure. Now let's look at different types of heart failure. Well, left-sided is first. With left-sided heart failure, you guys all know that means the blood is not moving in what direction? Forward. Okay, if it's not pumping the blood adequately forward, out the aorta and out here to my body, it goes backward into lungs. So let's look at the signs and symptoms in your book. When you read those signs and symptoms, we can tell that the blood is backing up into lungs. Yes, that's why the signs and symptoms are so pulmonary. Left equals lungs. Now right-sided heart failure is next. Okay, remember the blood is backing up into what system? Venous system. Venous system. So let's look at the picture. We know this already. The heart only wants blood to move in one direction. What is it? Forward. That's right. The heart only wants the blood to flow forward into lungs. The right side heart. Okay, well if the right side heart is sick, this means the blood is not moving forward adequately into lungs. So if it's not moving forward, well, where's it going to go back into? Venous system. Venous system. So the blood is backing up into venous system. That's why you get distended neck veins, edema, enlarged organs, all of those things. Now, you notice on the handout, we have new terminology for types of heart failure. Here we go. You have systolic heart failure, which is when the heart cannot contract and eject the blood. It cannot contract and eject the blood. Diastolic heart failure is when the heart cannot relax and fill. Now I want to talk about something else for just a second. Pulmonary embolism. Okay, think about this with me. If you have the pulmonary embolism, you're hypoxic, aren't you? Yes, hypoxia is the #1 cause of pulmonary hypertension. Okay, if you have high blood pressure in your lungs, what just happened to workload on right side heart? Increase or decrease? Increase, yes. So this person is at risk for right-sided heart failure. Okay, so what I'm saying is this. If you have somebody who has pure right-sided heart failure, it started with a lung problem, like hypoxia. Lots of things can cause hypoxia. Many things can cause your client to be hypoxic, like clots in the lungs. You know, you remember in nursing school when you studied COPD? Your teacher may have called it chronic airflow limitations. That's a new fancy term. Okay, COPD people, they're always hypoxic. And in the end stages, they always have right-sided heart failure, pitting edema, and ascites. All of those things due to right-sided heart failure. Secondary to pulmonary hypertension. Okay, now when people are in the heart failure, the doctor may do some diagnostic tests. Some doctors might put in a Swan-Ganz catheter. Not everybody does that. We used to, but not so much anymore because there's lots of complications that can occur. But let's talk about it for a second. Let's look at the heart again. A Swan-Ganz catheter. It's a type of central line. The doctor is going to go either in jugular or subclavian. And you know, this catheter, it has a balloon on the end, and it's leading the way, pulling the line, floating through the right atrium, right ventricle, and then it goes all the way out to pulmonary artery. Okay, this catheter, it helps us determine the cause of a decreased cardiac output. I need you to remember the killer complications. Air embolism, and pulmonary infarction. Those are the killer complications. The next thing we have on the handout is the A line, arterial line. Okay, this is an arterial line. It measures blood pressure. It measures blood pressure continuously on the monitor. I need to remember as the nurse, never put medication in the A line. That would be bad. Now, A lines are usually placed in what artery? Radial artery. Radial artery. Now in your notes, you'll notice it says Allen's test. That's what's next. Now this is done by the doctor or respiratory therapist or whoever's putting in the A line. We need to make sure, what this does is to make sure that your patient, client, has adequate alternate circulation. And we want this test to be positive. Positive means there's alternate circulation. Okay, what I'm saying is we've got to perfuse the hand. You don't want their fingers to fall off, do you? No. Okay, we've put in your notes how this is done. And you can read that over when you're studying. Okay, now you have to be careful with this A line because if you do not have the connections real tight, okay, or the stopcocks turned the right way in the proper position, your patient could bleed out. So be careful. That's the nursey thing. And we're checking when this person has an arterial line, we've got to check distal circulation. Distal circulation. Okay, so notice the 5 P's again, and we know what those are. Okay, and sometimes what we'll do in the hospital, if they have the A line, we'll go ahead and put it on an arm board. Sometimes we'll put it on the arm board for stabilization. Now let's look at some more diagnostic tests. B-type natriuretic peptide is next. This is a blood test. Okay, this BNP is secreted by the ventricular tissues in the heart. When the ventricular volume and pressures in the heart are increased, it is a sensitive indicator. It can be positive for heart failure when the chest x-ray does not indicate a problem. Now, if your client is on the Netracor, you need to turn it off. 2 hours prior to drawing BNP because it's going to give you a false high. Now, in congestive heart failure, our client is, some other things we need to look at is this, some more diagnostics, chest x-ray, well, and we're looking for a couple of things. Enlarged heart, and also we're going to look at the lungs to see if they have a lot of fluid, or pulmonary infiltrates. Pulmonary infiltrates. Now your client's going to have an echocardiogram. Echocardiograms, they look at the pumping action of the heart muscle. The next thing we have on the handout is a New York Heart Association functional classifications of persons with heart failure. Classes 1 through 4. Class 4 is the worst. Okay? It's just a scale to classify the degree of heart failure. Don't worry about all the numbers. For test purposes, they're not going to ask you the individual numbers on the test. For test purposes, I want you to remember, the higher the number, the worse the heart failure. Okay, now let's talk about treatment of heart failure. Medications are first. Digitalis, digoxin, lanoxin. Okay, this is most useful when the client is in atrial fibrillation and has heart failure. Well, what does digoxin do to a contraction? Makes it stronger. Makes it stronger. What does dig do to your heart rate? Slows it down. Slows it down. So think about that with me. When I slow the heart rate down, I just gave my ventricles more time to fill with what? Blood. Yes. More time to fill with blood. Okay, so now we're squeezing down on more blood with a stronger contraction. So what just happened to my cardiac output? Cardiac output just went up. It increased. We want to improve the cardiac output for somebody who has a heart failure. We're trying to get the blood to move forward. Okay, so think about this. My kidney perfusion just went up. So would diuresis be a good thing or a bad thing? Well, this is a good thing. We always want to diurese the heart failure clients because they cannot handle fluid. Would it be smart to give a heart failure patient whole blood? No, because you're going to throw them into pulmonary edema. Okay? Normally, we hardly ever give people whole blood unless it's autologous blood, their own blood. In other words, the client has donated their blood. If a client's having surgery, say like a hip surgery where they're going to need a lot of blood, then they might get this autologous blood. The majority of time, we give specific blood components to fix the problem. So if the client has a low H&H, then what are they going to get? RBCs, yes. If their platelets are low, then they're going to get platelets, okay? But again, my point is this. These people cannot handle extra volume. Now let's look back at your notes. The doctor is going to order a digitalizing dose, which is just a loading dose, because we're trying to build them up to a therapeutic blood level. So the first few doses are going to be larger than the maintenance dose the client is going to be sent home on. What's a normal dig level? 0.5 to 2. 0.5 to 2. Anything over 2 and they are toxic. How do I know the dig is working? Well, because cardiac output just went up. It increased. So turn to the person sitting next to you. See them? Okay? Start at the head and go to the toes and explain to them what you're going to look for to assess their cardiac output. You guys know, if you have a good cardiac output, LOC is going to go up. How's their skin going to feel? Warm and dry. Their lungs, they're going to be clear. Are they short of breath? No. Pulses are palpable. Palpable. Urine output just went up. Are they having any chest pain? No. Okay. So, next, look at the handout again. We have signs and symptoms of dig toxicity. Early signs are listed for you. Anorexia, nausea, vomiting. A late sign, weird arrhythmias that nobody can identify. And vision changes. Vision changes. I bet your teacher told you the client might start seeing yellow halos, right? Yellow halos. Okay, that's true for anybody taking the dig. That's what I worry about. So let's pretend that you have a client that's on the dig and they call you on the call light and they say, hey, everybody on the TV, they're purple. Well, you go into the room and when you get in there, they say, hey, you're purple too. Are you going to say, well, call me when I turn yellow? No, we have to assume the worst. Any vision changes on the dig and they're toxic. Okay, now then, before you administer the dig, what do you have to do? I heard you. Check a pulse. What pulse? Apical pulse. Where do we check the apical pulse? Tell me the exact spot. I know you memorized it for your cardiac checkoff on the physical assessment checkoff. And you told your teacher, the apical pulse, fifth intercostal space, mid-clavicular line. Fifth intercostal space, mid-clavicular line. Well, that's where it's supposed to be, but can it move around? Like, let's say I had ventricular hypertrophy. It can move. Or let's say I were pregnant. Or it could be way up here. It just depends on the patient. Don't expect it to be in the same place every single time. Monitor electrolytes. All electrolytes must remain normal. Hey, but potassium is the one that gives us the most trouble. Potassium is the one that gives us the most trouble. So here's what I want you to write down. Hypokalemia plus DIG equals toxicity. Equals toxicity. Any electrolyte imbalance can promote DIG toxicity. Even hyperkalemia can cause DIG toxicity, but usually hypokalemia is the culprit. The next thing I have listed for you, diuretics. They're all listed for you. Diuretics will decrease preload. Anytime we're decreasing volume, we're decreasing preload. Aldactone may be given to decrease aldosterone levels. And when do we give a diuretic? In the morning. You're a mean nurse if you give it at night. ACE inhibitors are next. ARBs, beta blockers. All those are listed for you. Hey, we have a little box to help you distinguish between the three classes of medications. It is standard practice that when a client has the heart failure, they're going to be sent home on ACE inhibitors and or beta blockers. Why? Well, these drugs will decrease workload on heart. They decrease the workload on the heart. They prevent vasoconstriction. They prevent the vasoconstriction, which will increase my cardiac output, keeping the blood moving in what direction? Forward. Okay, the client needs a low sodium diet. This will help decrease preload. Helps decrease preload. Okay? And we're watching, though, we need to watch salt substitutes because those salt substitutes can have a lot of excess potassium. Excess potassium, and that can be dangerous too. Also, this client needs to watch canned foods, processed foods, and over-the-counter drugs because all of those things can contain a lot of sodium. Yes. Okay. Next, it says on the handout, elevate the head of the bed, 10-inch blocks under the head of the bed. Okay, this helps, especially during the nighttime. It helps prevent heart failure because when people lie supine at night, venous return just went up. They cannot handle volume. Weigh daily and report any gain of 2 to 3 pounds, 2 to 3 pounds. And we've said this throughout this week. Remember, fluid retention, think heart problems first. Okay, report any signs or symptoms of recurring failure. And I know you know what those are. On the next page, we're going to talk about pulmonary edema. This heart stuff, it just keeps going. Now, we talk about pulmonary edema with heart failure people, but can other people get this as well? Yes. Like, let's say we give somebody some blood or normal saline really, really fast. They're at risk for pulmonary edema. Who are the other people at risk for pulmonary edema? This is what I want you to write at the top of the page. Any person receiving IV fluids really fast. Anybody getting the fluids really fast, the very, very young and the very old getting IV fluids. Any person that has a history of the big bad pump failure, anybody who has heart failure. And then one more person I want you to write down, anyone who has kidney trouble. Because we know the fluid is excreted through the kidneys, so anybody with the kidney trouble. Let's look at the patho next. You see, the heart, it's not pumping as strong as it should, so cardiac output goes down, and the fluid begins to back up where? Into lungs. So, signs and symptoms. The client is very hypoxic. When does pulmonary edema usually occur? at night when the client goes to bed. You see, all day when I'm walking around, this fluid, it's pooling in my legs, in my arms. And when I lie down, venous return just went up. Therefore, more preload. And they cannot handle this extra volume. Has a sudden onset. The client will be breathless. It's kind of hard to breathe when your lungs are full of fluid, right? And if the client cannot breathe, they might get a little restless and anxious. And I've said this before, or you've heard it in the class. Anytime you see restlessness, anxiousness, think what first? Hypoxia. Think hypoxia first. Now, your teacher may have told you they may have this productive cough, pink, frothy sputum. That's what it looks like. Well, treatment is next. Since this client has too much fluid, we need to decrease the circulating blood volume. So medications. Lasix will also cause the client to vasodilate. Well, this will trap more blood out in the arms and legs and reduce preload and afterload. Okay, we give 40 milligrams over 1 to 2 minutes to prevent hypotension. We've got to give it slow. We're preventing hypotension and ototoxicity. Since Lasix has a vasodilating effect, you always give it slow, IV, to prevent hypotension, to prevent the hypotension. And think about this with me. Normally, we don't like to trap the blood out here in the arms, legs, but I'd rather have it out here than up here in my lungs. You see? Bumix can be given IV push or as continuous IV to provide rapid removal of fluid. Give 1 to 2 milligrams IV push given over 1 to 2 minutes. Nitroglycerin can be given to vasodilate the client and decrease afterload. Well, let's talk about this for just a second. Decreased afterload increases your cardiac output because the heart is pumping against less pressure and more blood can move in what direction? Forward. Digoxin is next. Some people will even get this again today to get the blood moving in what direction? Forward. Morphine also causes vasodilation, which, like I said earlier, will help trap the blood out in the extremities. Vasodilation will decrease preload and afterload. Tell your friend, why is this a good thing? Well, we know because when you decrease the amount of blood coming back into the heart, you've decreased how hard the left ventricle has to work to pump blood forward. Morphine will also help decrease agitation, which is a good thing because if the client cannot breathe, they're probably going to be a little agitated. Netrocor is next. This is an IV infusion that's used for short-term therapy. It's not to be given more than 48 hours. Netrocor vasodilates veins and arteries and has a diuretic effect. Remember, don't forget to turn the Netrocor off 2 hours prior to drawing BNP. Primacor is next on the handout. This too is an infusion, continuous infusion used for short-term therapy that vasodilates veins and arteries. Dobutrex is next. Dobutrex increases cardiac output. Positioning for people in pulmonary edema. Well, we're going to place the client in what kind of position? Upright. Upright position, legs down. Upright, legs down. This position will help improve cardiac output. Okay? By sitting me up, this makes it easier for gravity to pull the fluid away from lungs. Keeping the legs down also promotes pooling of blood in lower extremities. Now, you most likely will not have to tell these people to sit up because when you can't breathe, you're going to sit up. The best thing to do is prevent pulmonary edema when possible. So we're checking lung sounds. We're checking lung sounds and we're avoiding fluid volume excess, overload. Remember, anytime you have a heart and kidney client, watch them closely and monitor the very young and very old clients placed on IV fluids. Cardiac tamponade is next. Let's look at the patho. This is when the blood, fluid, or exudate has leaked into pericardial sac, resulting in compression of heart muscle. Well, this can happen because the client has had a car accident. Maybe they were in a motor vehicle crash, or right ventricular biopsy, or MI people, myocardial infarction people, pericarditis, or hemorrhage post-CABG. Okay, this can occur with as little as 20 to 50 mils of blood that can accumulate in the pericardial sac. Now let's look at the picture and notice that the heart is being squeezed from the outside. Look at the signs and symptoms. Decreased cardiac output. This is because the left heart, it's being squeezed. Okay, focus on me for just a second. Let's pretend you're in fluid volume excess, overload. What happens to my CVP? Up or down? CVP goes up, okay? Fluid volume excess. What happens to my blood pressure? Increase or decrease? Increased. Why? More volume, more pressure. Okay, let's talk about fluid volume deficit. When people are in fluid volume deficit, what happens to their cardiac output? It goes down. Why? Less volume. Okay, when I'm in fluid volume deficit, we know blood pressure goes down. Why? Say it with me. Less volume, less pressure. Okay, so we all agree that the blood pressure and CVP, they like to do the same thing, don't they? Well, it doesn't work that way in cardiac tamponade. CVP is going to go up, increase, because the heart is being squeezed. Like when you're squeezing a balloon, the pressure will increase inside balloon due to increased pressure. Okay, but the BP is dropping because the cardiac output is dropping. Remember, less volume, less pressure. So the hallmark sign of cardiac tamponade is increasing CVP and decreasing blood pressure. Heart sounds, well, they're going to be muffled or distant. Neck veins will be distended, but your client is going to have clear lung sounds. Pressure in all four chambers is the same due to the fact that fluid is accumulating around the heart, squeezing heart muscle. Shock due to decreased cardiac output and paradoxical pulse, also called pulsus paradoxus. This is when the BP is greater than 10 millimeters higher on expiration than on inspiration. And a narrowed pulse pressure. This is the difference between the systolic and the diastolic. Okay, so the difference is getting smaller. For example, if the normal BP were 120 over 80, then the normal pulse pressure would be 40. So that means that the pulse pressure, when it drops less than 40, worry. Okay, that's just an example on your handout there. Let's say my baseline BP were 90 over 60. What's my pulse pressure? 30. You see, that's just an example. In that case, then, we'd worry if it dropped below 30. Okay, good. Now let's look at treatments. Pericardiocentesis is next. Well, this is done to remove the blood from around the heart. With this one, the physician will take a needle and insert it into pericardial sac. Pericardial space is what I meant to say, and remove the fluid. Or surgery. The surgeon will remove a portion of the pericardium to allow the fluid to drain. With this surgery, the client may come back with a drain in place. So we're monitoring the fluid. On the next page, arterial disorders are next. Hey, arteries carry what type of blood? Oxygenated blood. Hey, if you have atherosclerosis in one place, you have it everywhere. It is a medical emergency if you have an acute arterial occlusion. The client will complain of numbness and pain. The extremity will be cold. There will be no pulse, palpable. In other words, the 5 Ps. Again, arterial disorders are more symptomatic in the lower extremities. Now, intermittent claudication is next. This is an arterial disorder. Okay, pain. Pain is the hallmark sign with intermittent claudication. You only have intermittent claudication with arterial problems. It's not a vein problem. Okay, here's a critical thinking exercise to help explain this disorder. Let's say that I have this arterial disorder in my left leg. I may not know it yet, but I could walk from the flat ground and start walking up a steep hill. When I'm walking up the steep hill, we know oxygen demand just went up. Well, if I have this problem, the oxygen cannot get to my muscle cells. So I move from aerobic to anaerobic metabolism. Therefore, what builds up? Lactic acid, and it hurts. You know, ladies, it's similar to what we did. I know what y'all have done. You go to the Walmart and you get that workout video. You know the one I'm talking about. And that guy on the video, what does he say? Make it burn, because you're moving from aerobic to anaerobic metabolism, and it hurts. That's why you never ever did it again. Okay, but remember, the problem is this. Arterial blood isn't getting to the tissue. Okay, arterial blood is not getting to tissue. So you get these things: coldness, numbness, decreased peripheral pulses, atrophy, decreased muscle tone from lack of oxygen. Bruit can occur. Skin, nail changes, ulcerations. Anytime you see bruit, think turbulent flow. Turbulent flow. You know, they're going to get skin that's real dry and scaly, and put a big star by decreased peripheral pulses, as that is the priority nursing assessment. A man with an arterial problem, they'll have that one leg will be hairless because they do not have good circulation. And what kind of nails are they going to have? Thick, brittle nails? Can the area become ischemic and necrotic? Well, yes. Could it lead to black crunchy toes that fall off? Yes. Hey, rest pain means severe obstruction. If all the client has to do is stand there and they start having the pain, the burning, that's real bad. They need to seek medical attention. Now, you and your friend look at the next sentence under treatment and see if you can figure it out. Since the arterial blood is having problems getting to the tissue, if you elevated the extremity, would it cause pain? Would it cause this pain to increase or decrease? Increase. Okay, because remember, what do arteries do? They carry blood to the rest of the body. If you elevated this extremity, you just made it harder to pump uphill. So the pain would increase. You just made it worse. Okay, you dangle the affected limb. You've got to dangle it to increase perfusion. Leg-dependent position for these people to increase circulation and perfusion. You elevate vein problems and you lower arterial. Elevate veins, lower arterial. Arterial disorders of the lower extremities are usually treated with either angioplasty, balloon or stent, or endarterectomy. The doctor is going to make the decision. The purpose of both of these procedures is to enhance perfusion. Enhance perfusion. Now let me tell you something. If you ever get an artery question, you automatically know there's a part of the body that's not getting oxygen. Okay, sometimes they may give you a name of an artery that you've never heard of before. But if you can figure out what it supplies, you will be okay. See, the NCLEX lady, she wants to know, are you going to think artery? Or are you going to click C and hope for the best? Here's a hint. If you know the artery, try to figure out what it is feeding. You know my radial artery feeds my hand. My carotids feed my brain. Femoral, my legs. Okay, let's pretend I've had a carotid endarterectomy. We've already said the purpose is to enhance perfusion. Ask your friend, how will I know whether or not this procedure was successful or unsuccessful? Well, first of all, let me ask you this. What do the carotids feed? They feed my brain. Okay, therefore, LOC is going to go up. Okay, so listen to me for a second. Here's some common answers that we get. Let's say you had to pick shiny hair, increased temporal pulse, or increased LOC. Which one you going to pick? Increased LOC, okay? Because the most important thing I'm worried about is my brain. Now, let's pretend that your client had an abdominal aortic aneurysm repair. How do I know whether or not this surgery was successful? What are all the things you're going to check? Well, you're going to check the pulses from the waist down. So you're checking femoral, popliteal, pedal pulses. Yes? Hey, with this person, would it be important to monitor their urine output? Why, yes, because could this surgery interfere with the renal artery? Yes, so we're monitoring urine output very closely. When someone has a dissecting aorta, their aorta is dissecting. What is the major complaint? Severe back pain. Severe back pain. You know, usually it's pulsatile back pain because as the aorta is dissecting, it's tearing, it's ripping with each pulse. So they have pulsatile back pain. Okay, now let's look at two really weird arterial disorders. Buerger's disease, signs and symptoms. This is inflammation of the arteries and veins. Inflammation of arteries and veins. It's classified as an arterial disorder. This is the one the men get. It's related to heavy smoking, cold, emotional upset. Put a big old star by the word vasoconstriction. Okay, when you vasoconstrict an artery, what do you do to the oxygenation? You cut it off. You cut it off. Okay, this usually occurs in the lower extremities, sometimes in the fingers, but usually in the toes. Okay, here's the scenario. Ladies, what do men like to do on Monday night? Watch football, okay? Well, let's pretend for just a second this is your husband. And he's sitting in his favorite Barca lounger, watching his favorite football team play football. Okay? Well, he's watching the game and his favorite team starts to lose. So he starts cursing at the TV. He starts jumping up and down, cursing at the TV. Maybe he's smoking a cigarette too. Halftime comes and he sits down. And he looks at you. And you're in the kitchen, studying for NCLEX, cooking dinner and feeding the baby. And he says, honey, my toes, they feel numb. What are you going to tell them? Y'all don't be mean. But people don't worry about the numb toes, do they? But could it lead to the black crunchy toes that fall off? Yes. So what is he supposed to do? Avoid the cause. Avoid the cause. Stop smoking. Avoid the cold. Hydrate them. Hydrating them thins out blood. Thins out blood. Okay, bypass surgery maybe. They need to wear shoes that fit well. Avoid trauma to the feet. Avoid trauma to the feet. Sounds like the diabetic person, doesn't it? Anytime we have people who have decreased perfusion to their feet, we need to ensure they're doing good foot care. Avoid injury. And finally, they might have to have amputations of these black crunchy toes. Okay, ladies, we have not been forgotten. Raynaud's disease is next. Signs and symptoms. Okay, this usually occurs in female fingers. Think female fingers. It's the same as the Buerger's, but it happens in the female fingers. Okay, it usually occurs bilateral, both hands, usually to the fingertips. The fingers turn white, then blue, then red. It's a very patriotic problem. Here's what I need you to do. Write vasoconstriction out to the side. Vasoconstriction out to the side. It happens whenever she gets cold, upset, or smokes. It's painful and can cause ulcerations. And yes, it can lead to black crunchy fingers. And the treatment, the best thing is to avoid the cause. Now here's the critical thinking exercise. Since you've been a nursing student, are you getting strange calls from distant cousins you've never heard of before? Let's pretend that this cousin, they call you and they say, hey, it hurts when I put my hands in the freezer. What are you going to tell them? You can't just say, stop putting your hands in the freezer. That would be mean. They want to get dinner. Avoid the cause. So you tell them to wear gloves, things like that. Okay, avoid the cause. That's the key. Now let's look at DVTs. That's next. Veins carry what type of blood? Deoxygenated blood. Okay, we're going to look at the patho. Here we go. Blood stasis, vessel injury, blood coagulation. You see, with vein problems, the blood can get to the tissue. It just can't get away. It's trapped. So it sits there, stagnates, irritates, and chronic ulcers can occur. Okay, the thing is this. With vein problems, you do not have an oxygenation problem. But doesn't it always sound right to pick oxygenation with vascular problems? Well, it's wrong here. Okay? The oxygen can get there. It just can't get away. So it sits there, stagnates, irritates. Inflammation can occur and chronic ulcers can occur. Signs and symptoms: edema, tenderness, warmth, and a positive Hohmann's sign. You know that Hohmann's sign? It's very controversial because we know you can dislodge the clot. Treatment. Well, what are the anticoagulant drugs that we give? They're listed there for you. Heparin, fibrinolytics, Coumadin, Plavix, aspirin, Lovenox, or Percentin. See the box? You also notice that we've given you guys normal lab values, PT, PTT, INR. These drugs either prevent platelet aggregation or prevent the clot from getting bigger. Okay, what do we tell these people to limit in their diet while they are on the Coumadin? What should they limit? Green leafies. Green leafies. Now, they can still have some, but no more than 3 times per week. No more than 3 times per week. What do green leafy vegetables have a lot of? Vitamin K. Vitamin K. Hey, you don't want them eating the antidote now, do you? No, no more than 3 times a week because they don't want, you shouldn't let them eat the antidote. That would be bad because if they do and they're on the Coumadin, they're going to get a clot. Okay, when clients are on any of the drugs that we have listed here in the chart, in the book, we teach them to follow bleeding precautions. And you know what those are: soft toothbrush, no razors, electric razor, avoid bruising. Okay, surgery, maybe, just depends on the client. And this client is going to be on bed rest. We don't want these people running around. We don't want them to dislodge the clot. In fact, that's the number one thing I worry about with the DVT, dislodging the clot. Okay, when that happens, now it goes to the lung, and they got the PE. Are they happy now? No, that's not good. Okay, we're going to elevate their extremities because we want to increase blood return. To decrease pooling in the extremities. To decrease pooling in the extremities. TED hose to increase venous return, and decrease pooling. Okay, they must be fitted on this client. You know, they come in small, medium, large. How often do we remove the TED hose? Twice a day, or once a shift. Now, how often do we actually remove them in the hospital? Never, because they're so hard to get back on. Many times you'll see the doctor order SCD hose to be used with TED hose. It's the doctor's decision. Hey, but if your client already has a clot, they may not use TEDs or the SCDs. We're going to use warm, moist heat. That's important. Never put cold on a vein. Warm, moist heat to decrease inflammation. To decrease inflammation. Notice I said warm, moist heat, not hot heat. Hot heat causes too much vasodilation. You might just dislodge the clot. And lastly, prevention is the key. We want to ambulate and hydrate the client. We also want to put this person, the SCDs, We also want to put the SCDs on this client and do isometric exercises. Okay, last scenario. Let's pretend that you're taking care of a client on the med-surg unit and they had past surgery, and you walk by him and the patient says, "Hey, I'm going to get to go home. All I need to do is void one more time." And you're like, "Great, wonderful. So everything feels fine?" The patient says, "Yeah." The client says, "Yeah, I'm fine, except for this cramp in my leg." Everybody in here knows we have to assume the worst. What are you going to do? You're going to get the weight off the leg. Don't leave them. Call for help. Get me the wheelchair. You're going to get them in the wheelchair. Then you're going to get them to the bed. Transfer. Do not let them bear weight on that leg. And when they get into the bed, you're going to elevate. We're going to elevate the leg and then call the doctor. You see, you just did a whole lot of things right there before you called the doctor. On this test, they want you as a nurse to do some things to fix the problem. Rule, never delay treatment. If there's something that you can do to promote safety or help treat the client, do it before you call the doctor. Never delay treatment. And always assume the worst. Okay, y'all, that's enough on cardiac.